Good day. Today we will talk about hemorrhage shock in obstetrics and dissemination intravascular coagulation syndrome. Hemorrhagic shock, the first we will talk about definition. It is condition in which inadequate perfusion of organs results in insufficient availability of oxygen to satisfy the metabolic needs of the tissues. The second, a catabolic state develops, and the consequences of this change are inflammation, endothelial dysfunction, and disruption of normal metabolic processes in vital organs. What we need to know to maintain perfusion: the first is the heart, it is a pump, the pipes is the blood vessels, and fluid is the blood. Type of shock: the first is hypovolemic shock, cardiogenic shock, neurogenic, and anaphylactic shock, and at last septic shock. Obstetrics cases of shock: the first, blood loss, obstetric hemorrhage. Obstetric hemorrhage, sometimes it is a severe hemorrhage and we have high risk of maternal death. Bleeding in early pregnancy, antepartum hemorrhage, postpartum hemorrhage, fluid loss during hyperemesis gravidarum, diarrhea and ketoacidosis, plasma loss during severe burns, supine hypertension syndrome, splanchnic shock. It's a sudden drop in intrauterine pressure during hydroamnios. I want to talk about antepartum hemorrhage. It is a bleeding from or into the genital tract after 24 weeks of pregnancy before onset of the labor. Antepartum hemorrhage complicated 3 or 5% of pregnancies. Severity of antepartum hemorrhage, no consistent definition. Presence of maternal shock and fetal compromise or demise are important indicators of volume depletion. Severity: it's spotting, it's minor hemorrhage, and massive hemorrhage when patient blood lost more than 1,000 milliliter and or signs of clinical shock. And recurrent antepartum hemorrhage, it's episode of this hemorrhage on more than one occasion. It's very, we have in this situation, we have very high risk of shock and maternal death. Another obstetrical hemorrhage, the most common form of hypovolemic shock in obstetrics is hemorrhagic shock due to massive obstetric hemorrhage. Blood loss associated with pregnancy or parturition that causes maternal or perinatal death requires blood transfusion, decrease hematocrit by 10 points, triggers emergency therapeutic response. Categorization of acute hemorrhage is when the blood lost at class 1, it's more than 15%, but pulse rate, pulse pressure, blood pressure is normal. When we have abnormalities, if we have patient with class 3 and class 4, when the blood loss more than 30 till 40% and pulse rate is more than 120 and blood pressure is decreased. At class 4, the pregnant woman lost more than 40% and the pulse rate is more than 140 and the pulse pressure and blood pressure decreased too. Shock index, it's equal to heart rate to the systolic pressure. Normal if it's more than 0.5. And for example, if you saw this picture, shock index during the severe bleeding is more than 2 because the patient lost 2,500 till 3,500 milliliter of blood and loss of the blood volume more than 50 or 70%. It's a very severe condition when we load the patient. It's emergency situation, yes. Signs and symptoms of the shock. It's hypertension, rapid weak pulse, pallor, sweating, cold clammy extremities, oliguria or anuria, and at last confusion. Stage of shock. Compensated shock, its defense mechanism or successful in maintaining perfusion. The first presentation is tachycardia, decreased skin perfusion, altered mental status. Uncompensated, irreversible. It's the first defense mechanism begin to fail, and the first presentation, it's hypertension, marked decrease in heart rate, rapid, rapidly pulse, agitation, restlessness, and confusion. And at last, complete failure of compensatory mechanisms and marked loss of tissue perfusion cause cell damage and death, even in presence of resuscitation. We lost the time and we lost so much blood. We can't help for this patient. Initial assessment of the bleeding patient requires monitoring. It's a blood pressure, pulse, capillary refill, mental status, and urinary output. This allows estimation of the amount and the rate of blood loss and helps direct treatment. Maintain the following. The first is systolic pressure more than 90 millimeters. And urine output more than 0.5 milliliters per kilogram to hours. Normal mental status. Eliminate the source of hemorrhage. Avoid overzealous volume replacement that may contribute to pulmonary edema. It's very important when we measure management goals. The first principal goals of the management are controlling the source of the blood loss, restoring adequate oxygen carrying capacity, maintaining adequate tissue perfusion, and at last, patients with a severe postpartum hemorrhage have risk of developing hypothermia. It must be prevented or treated promptly. At emergency department, we need to know about it. It's help for the patient. And initial treatment in the shock, the first require maintain airway, apply high concentration of oxygen, assist ventilations as needed, place patient in the Trendelenburg position, control obvious bleeding, and prevent loss of body head. Restoration of circulation volume fluid choices. Insert at least 2 large pore for catheters, crystalloids for initial resuscitation, and third, rapidly infuse 5% dextrose in lactated Ringer's solution, while blood products are obtained, and colloids and red blood cells to replace blood loss. Blood. If order at least 6 units of red cells, don't insist on cross-matched blood if transfusion is urgently needed. Apply compression cuff to infusion pack and monitor central venous pressure and arterial pressure, because it's very important to check it. If we don't do it, we have so much complications. Complication of hypovolemic shock. The first, acute renal failure, pituitary necrosis, it's Sheehan syndrome, and disseminated intravascular coagulation. Obstetrical bleedings in the first half of pregnancy. The first etiology, it's abortions, it's early abortions, miscarriage, ectopic pregnancy, gestational trophoblastic disease, you know it's a mole disease, and at last cervical cancer. Ectopic pregnancy. And today we will talk about definition, classification, etiology factors, pathophysiology, clinical presentation, and at last the treatment. Classification. The first, in 95-96% cases we have tube pregnancy. If it's interstitial and coronal tube pregnancy, it's a little, this kind of patient have severe bleeding, and they come to the hospital with a shock by emergency car. And we have this situation in 2 or 3% cases. Ischemic 20% cases, and ampular 70% tube pregnancies. It's not very dangerous, not so dangerous like the interstitial and corneal tube pregnancy. Abdominal pregnancy in 1% cases. We have primary and secondary abdominal pregnancy. Ovarian pregnancy in 3% cases, and cervical pregnancy in 1% case. It is a very dangerous situation if we have cervical pregnancy, because these kind of patients have severe bleeding and sometimes they need to have hysterectomy and extirpation of the uterus. And sometimes extrauterine pregnancy situated in rudimental horn if the patient have a bicornuous uterus or unicornuous uterus or some abnormalities with genital tract, intraligamental uterus, rare in the liver, amental, diaphragm. It's an abdominal pregnancy in abdominal cavity. And pregnancy inside cesarean scar, it's less than 1% cases, and heterotopic combinated 1 to 30,000 patients. Sites of implantation, it's interstitial implantation, it's cervical implantation, intramural implantation, abdominal, if intramural, if it's in the cesarean section, ovarian, ischemic, ampular, fallopian tube. You saw the fallopian tube have 3 parts. It's ampular, ischemic, and infundibular part. And we have 3 type of situated of this embryo. Risk factors. The first, it's salpingate, inflammatory problems, inflammatory of tubes, hormonal dysfunction, very often deficiency of progesterone, tubal corrective surgery, some surgeries, adhesions, tubal sterilization before, intrauterine device. Sometimes the patient have intrauterine device for protection of the pregnancy, but they have these complications: documented tubal pathology, infertility, previous genital infection, chlamydia, IVF, and tubal peritoneal causes, peritubal adhesions. These peritubal adhesions, we have the patient with endometriosis, you know about it, and with the patient which last and from their anamnesis they have surgical intervention during their life. Tubal pregnancy can be progressive, discontinued, tubal rupture, and tubal abortion. If we have tubal rupture, the clinical signs, bleeding and massive bleeding, and sometimes when we have tubal abortion, the patient have bleeding but not so much blood, a little bit blood, a little bit portion, and they not in confused. They have normal arterial pressure, but they have a little bit dizziness, a little bit weak pulse, and they come to physician because they have abnormal menstrual cycle, and they say, I have no menstruation approximately 1 month or sometimes, and we check them. The first, how can we check? We check ACG hormone, it's chorionic gonadotropin hormone, and make ultrasound investigation. During normal pregnancy, if level of ACG hormone must be more than 1000, and we can check and find embryo intrauterine. During tubal pregnancy, we have ACG hormone, we have absence of menstruation, and the test is at the pregnant woman, but we have empty uterus, and because it's the embryo situated extra in tube, maybe in ovarium. At this picture you saw the dilation of the tube, and at the next picture you saw that big hematoma in front of from the right side of the left side of the uterus, because we have rupture of tube. Here we have extrauterine pregnancy, and we have embryo, approximately 8 till 6 weeks of pregnancy. Abdominal pregnancy, it's so rare. We have this complication, but in this situation we have phase of embryo that seems to be growing within the abdominal pregnancy. Abdominal pregnancy, sometimes it is primary, but mostly it's secondary. It's like abortion from the tube, but placenta situated near the liver, intestine, and it is a very dangerous situation. If we have big pregnancy, we have very high risk of bleeding, and during cesarean section we need to have so much specialists, it's surgical surgeons. Abdominal pregnancy, we saw during ultrasound the empty uterus. Before, in front of the uterus, it's bladder, a little bit fully, and from the left side, the big fetus, approximately 16 weeks of pregnancy. Here we have abdominal pregnancy and big placenta situated near the intestinum, and it is very dangerous, but a live baby. It's so rare that in my practice I haven't seen this kind of patients. Abdominal pregnancy, you saw that the fetus a little bit changed, but he's alive. Here we have ovarian pregnancy. On the left picture we have full uterus, it's normal pregnancy. In another picture you saw that the ovarian with hematomas and the pregnancy situated inside. Pregnancy in rudimental horn, it's dangerous too, because very often this kind of patient have abnormalities of the fetus, fetal death, retardation syndrome, and fetoplacental deficiency, and abruption of the placenta, and another complications. Cervical pregnancy is very dangerous too, because in the cervical channel we have no decidual transformation, and between chorion and between embryon and a cervical channel, they begin and develop big vessels, and we have after curettage, after abortion, this kind of patient have acute bleeding, and we need to help. Many years ago we came to help, and the obstetrical surgeon make hysterectomy and very often extirpation of the uterus, because they have bleeding from the cervical channel. And nowadays they can help with methotrexate, use methotrexate and use hysteroscopy, and they coagulated damaged vessels and help for save the uterus for the woman. How can we make diagnosis? The first, it's history, analysis, bimanual examination, but not only bimanual. Very important, you need to know when we may check the cervix, we need a scapular exam, scapula. You know, during scapular exam, we observe the cervix, external os, vagina, ultrasound investigation, and we use abdominal and vaginal transducers, ACG hormone level, diagnostic curettage, and cholecystectomy. How can we treat? The first treatment is surgery, laparoscopy or laparotomy. It's depend of the surgeon and depend of the clinic. Sometimes they have they're in the village, they're outside of the city, and they have just laparotomy, and it's not the mistake, and we need to help for the patient. But mostly in nowadays we use laparoscopy. And medicamentoses, it's when we use methotrexate, you know that it's cytostatic drug, and it's a medical treatment of extrauterine pregnancy. At this picture you saw that laparoscopy surgery, we have tube pregnancy, and they make salpingostomia. They cut the tube, make extraction of ectopic pregnancy, and make salpingostomia. But after, when we leave the tube inside, we need to use methotrexate because we can't make curettage of the tube, and some a little bit cells of the embryo stay there. And when we have good result, the first it's menstruation after the surgery, and ACG hormone less than 10. And after menstruation, we check ACG hormone, it will be zero, like a non-pregnant woman. Premature abruption of placenta. The first we talk about definition, etiological factors, pathogenesis, clinical presentation, treatment, and last complications. It's very severe situation when we have separation of normally situated placenta after 20 weeks of pregnancy. Incidence in 1% of all pregnancies and 6% of maternal deaths. You saw that just 1% and 6% of maternal deaths. It's very important because sometimes the abruption of placenta begin acute emergency, and the patient lost so much blood, and we can't help her quickly. The first risk factor is hypertension, it's tension at 44%, it's trauma, 2 or till 10% cases, smoking because it damage vessels, drug like cocaine, make vasospasm, short umbilical cord, maternal age more than 35 years old or less than 20 years old, sudden decompression of uterus, it's delivery of the first twin, retroplacental myoma, amniocentesis, more than 24 hours, yes, premature delivery, history of placenta abruption 4 or 12%, after 2 episodes 25%, and low socio-economical status. At this picture you saw normal placenta and placenta abruption. From the center of placenta and between placenta and uterus wall collected the blood, and this collection of the blood formed to big hematoma, and it separate the placenta again and again. Classification by degree of separation. The first is partial, total, and by localization, marginal and central. Pathology mechanism. The first is hemorrhage into the deciduo basalis, deciduo splits, deciduo hematoma, and separation, compression, destruction of placenta adjacent to it. And type of abruption. The first, revealed abruption, concealed abruption, and mixed type. Abruptia placenta. Revealed abruptia, if we have a little bit blood come out from the cervix and from vagina, and we can make diagnosis. And the second is concealed abruptia, when we have a big concentrated hemorrhage between uterus wall and between placenta. It's very dangerous because we have problem with the heart rate of the fetus. We have high risk fetal and maternal death in this situation. Classification, it's depend of the clinic situation. The first, it's asymptomatic, mild, 48% cases, non-severe 27% cases, and at last severe 24% of patients. Classification, if we have asymptomatic, it's retrospectively clot or depression on placenta. Mild is a bleeding absent or mild, uterus is tender, blood pressure and pulse are normal, coagulopathy, we have no coagulopathy, and fetal distress not. In the moderate, we have bleeding, not or in moderate degree, uterus tenderness more than significant, spastic sometimes, we have some contractions, tachycardia, blood pressure is changed, fetal distress, and hyperfibrinogenemia. Less than 250, but more than 50. Severe, if we have bleeding, node, or severe, uterus is extremely painful or tender, shock, the patient have shock, hyperfibrinogenemia, and coagulopathy, cavaliers uterus, fetal death. What the meaning cavalier uterus? It's ischemia of the uterus wall. Symptoms, the first, in 80% cases, we have vaginal bleeding, abdominal or back pain, and uterine tenderness at the 70% cases, fetal distress, 60%, abnormal uterine contractions, hypertonus frequency, and in the 35% cases, like discoordination, hypertonus, tetanus of the uterus, and idiopathic premature labor in 25% cases, and stillbirth in 15% cases. This picture you saw hematoma, hemorrhage, and big hematomas behind the placenta. At this ultrasound picture, you saw that fully abruption of placenta, so much blood between the uterus wall and between placenta, and stillbirth of the fetus. It is Cavaliers uterus. Cavaliers after, who's the first tell us about this and wrote some article, and you saw that so much ischemic zone in the uterus wall. In this situation, sometimes we can't leave the uterus and make hysterectomy or extirpation because we have high risk of hemorrhage, postpartum hemorrhage, and high risk of sepsis and peritonitis. Differential diagnosis: the first, abdominal trauma, acute appendicitis, disseminated intravascular coagulation, ovarian tumors, torsion of pendiculus ovarian cyst, placenta previa, ectopic pregnancy, preeclampsia. It is a very severe situation. We have preeclampsia, hemorrhagic shock, hypovolemic shock too. Intensive care depends on gestational age and severity of symptoms. The first step: monitoring, oxygen, fetal monitoring, intravenous infusions. The large fluid volume to maintain adequate perfusion if it's needed. Vital signs and urine volume, red blood cells for unit, blood transfusion if it's needed. Amniotomia aim to reduce hypertonus, prevention of uterine placental apoplexia, and trophoblastic substances entering the bloodstream. Emergency cesarean section in case of non-stable condition of mother and fetus. Treatment of coagulopathy and disseminated intravascular coagulation if needed. Coagulopathy in 30% of cases. Diagnosis, clinical features. The first, how can we make this diagnosis? The first is vaginal bleeding associated with persistent abdominal pain. Abdominal pain is acute pain in the stomach. Tenderness of the uterus, woody hard uterus, change of fetal heart rate, and features of hypovolemic shock. At this picture, we saw big hematoma behind of the placenta, very big hematoma. So much blood lost this pregnant woman. At this picture, we saw the fully abruption of the placenta and retroplacental hemorrhage. Management. The first depend on mother's degree of blood loss and fetus condition. If we have big pregnancy, we make emergency cesarean section. In mild degree and gestational age less than 36 weeks, we make monitoring. Non-severe maternal and fetal distress or mature fetus prompt delivery and severe hysterectomy. Complication. We have complication of the mother and complication of the fetus. The first, maternal disseminated intravascular coagulopathy, hypovolemic shock, amniotic fluid embolism, renal tubular necrosis, and acute renal failure, postpartum hemorrhage, maternal death, uterine rupture, and fetal complication, very dangerous, premature delivery and premature newborn, intrauterine retardation syndrome in chronic abruption, hypoxic ischemic encephalopathy and cerebral palsy, fetal death. Investigation. The first, ultrasound investigation, mainly to exclude placenta previa, can detect the first, reproplacental hematoma, fetal viability. Most of time finding will be negative, but negative findings don't exclude placental abruption. You must be very it's very important to check the patient again and again. Second, laboratory investigations, investigation for consumptive coagulopathy, platelet count, yes, and PTT, liver and renal function test. We talk about clotting factors. It's very important. And enzymes, liver enzymes. Placenta previa, definition, classification, pathogenesis, clinical presentation, complication, and treatment. Placenta previa, it's very dangerous diagnosis during the pregnancy because the presentation parts must be parts of the fetus, head or the breech, but sometimes insertion of the placenta partially or fully in the lower segment of the uterus, it is placenta previa, mostly at multipara and placenta migration phenomenon. You don't forget about it. Sometimes the placenta is situated at the lower segment, but during the pregnancy, it's find the better place and migration. Normally, if margin of placenta higher above the internal os, approximately to 6 centimeters. If it's less, we said about lower situation of the placenta. One patient to 250 deliveries. Risk factors. The first, history of placenta previa before, history of cesarean section or some another uterine surgery, multiple curettage or of uterine cavity, so much abortions, cervical insufficiency, multiple pregnancy, multiparity, extragenital diseases, advanced maternal age, intrauterine structural anomaly, and in nowadays IVF and extracorporeal fertilization is a risk factor too. Etiology factors. No definitive cause. The first, endometrial factors, scarred endometrium, curettage with several times, abnormal uterus, and placental factors, large placenta, abnormal formation of the placenta. Classification, complete, partial, marginal, and low-lying. Complete covers the os even when the cervix is dilated during the delivery. Partial placenta previa covers part of the internal os. Marginal placenta previa reach internal os but doesn't cover it. Low-lying placenta encroaches lower segment but doesn't reach the internal os. The first diagnosis is hemorrhage. Uterus is tender, isn't tender. Without some contractions, the patient have bleeding. The third, external obstetrical examination. During Leopold examination, we find the soft tissue above the symphysis, and we can't find the head, and it is sign too. Ultrasound investigation, vaginal examination must be gently and very careful because during placenta previa, our examination can be reason of the bleeding. Prenatal diagnosis of this pathology relies on the capacity to visualize the internal cervical os and its relationship with the lowermost edge of the placenta. Placenta previa exists when the placenta is inserted wholly or in part into the lower segment of the uterus. Clinical features: recurrent painless vaginal bleeding, not very often. Abdominal findings: the first, uterus is soft, relaxed, and non-tender. Contraction may be palpated. Presenting part is usually high and very often abnormal presentation, transversus or obliquant lie of the fetus. Maternal breech presentations: maternal cardiovascular compromise, fetal condition satisfactory until severe maternal compromise. Vaginal examination should not be done. If we make before ultrasound investigation and we make diagnosis before, we don't do vaginal examination. But if we have no ultrasound investigation, we think about it, it must be gently and careful. Diagnosis. Make diagnosis: follicularization of placenta. The first ultrasound, abdominal ultrasound, can easily diagnose placenta previa with an accuracy of 93–97% cases. Transvaginal ultrasound is safe and more adequate in this situation because it's more accurate than transabdominal ultrasound in locating the placenta. Hematological investigation: the first, complete blood picture, blood grouping, renal profile. Complication: maternal complications: minor hemorrhage, shock and death, renal tubular necrosis, acute renal failure, postpartum hemorrhage, morbid adherence of placenta, placenta accreta in 10% cases, anemia, chronic hemorrhage infection, disseminated intravascular coagulopathy. In fetal intrauterine death, hypoxic ischemic encephalopathy, cerebral palsy, placental abruption, premature labor. And placenta previa management: near-term delivery is considered. Types 1 and 2 may be able to deliver vaginally, but types 3 and 4 will require cesarean section by senior obstetrician. Placenta previa management: if we have early in pregnancy, continuation of pregnancy better if possible, need bed rest, adequate patient recurrent condition and risk, 3 pints of crosses matched blood should be available till delivery. Fetal will bake and growth should be monitoring by ultrasound, Doppler velocimetry and CTG, cardiotocography, and medication may be given to prevent premature delivery with nifedipine and atazibam. Management: we give spasmolytics, treatment of fetal hypoxia, anti-anemic treatment, cesarean section and amniotomy. Vasa previa: fetal blood vessels from the placenta or umbilical cord cross the internal os beneath to the fetus. Rupture of membranes lead to damage of the fetal vessels, leading to blood loss or death. High fetal mortality, very high, approximately 50 or till 75% cases. Vasa previa, so that before the head, between the internal os and head, situated fetal vessels. It's very important to check during ultrasound investigation, and if we make diagnosis, we make cesarean section. Risk factors: eccentric filamentous cord insertion, lobed of success-nutriated lobe of placenta, multiple gestation, placenta previa, in vitro fertilization, pregnancies, history of uterine surgery. Eccentric filamentous cord insertion. During ultrasound, we can check the situation and make diagnosis. Diagnosis: moderate vaginal bleeding and fetal distress. During CTG, vessels may be palpable through dilated cervix. If we have the first period of delivery, vessels may be visible on ultrasound, transvaginal color, Doppler ultrasound, difficult to distinguish from abruption. Can look for fetal hemoglobin. Yes, it's Klein-Hare-Bethke test, or nucleated red blood cells in sheet blood, and tachycardia or bradycardia during CTG investigation. Management of antepartum hemorrhage. Admit to the hospital for assessment and management. Very important. May need resuscitation measures if shocked or severe bleeding, airway, breathing and circulation, 2 wide bore cannula, take blood for grouping, coagulation, profile, liver and renal function, liver enzymes. It's very important to check the blood grouping, because if we have risk of hemorrhage, we need to know about it. Management. Volume should be replaced by crystalloid colloid until blood is available. Severe bleeding or fetal distress, it's urgent delivery of baby irrespective of gestational age. History. Obtain a history if patient's condition allow, including color and consistency of bleeding, quantity and rate of blood loss, precipitating factors. If it's sexual intercourse, sometimes they can say us, but we need to ask. Vaginal examination, degree of pain, site and type, placental location, review ultrasound report if available, a certain fetal movement, a certain blood group. Management examination, assess maternal and fetal well-being, pallor, record temperature, pulse and blood pressure, perform abdominal examination, note areas, it's very important, of tenderness and hypertonicity, and maybe sometimes they have contractions. Determine the gestational age, presentation and position, auscultate fetal heart. No vaginal examination should be attempted at least until a placenta previa is excluded. We need to make ultrasound investigation. Firstly, do speculum examination to access service, bleeding and exclude local lesions. Management, the first investigation, urgent ultrasound scan and CTG, it's cardiotocography. Further monitoring of antepartum hemorrhage. First, it's the cause of antepartum hemorrhage, extent of bleeding, presence of fetal distress and gestational age and fetal maturity. It's a very important gestational. If it's big pregnancy, we don't wait and we make emergency cesarean section. Vasa previa management. The first, it's urgent delivery, most of the time urgent cesarean section. Neonatologist involved an aggressive resuscitation of the baby with blood transfusion following delivery. Prognosis of antepartum hemorrhage. Fetus may die from hypoxia during heavy bleeding. Perinatal mortality more than 50 per 1,000, even with tertiary care facilities. High rate of maternal mortality. Placenta accreta, it's a very dangerous situation when we have placenta accreta. Occurs when there is an attack of deciduo basalis in conjunction with an imperfect development of the Nittabach membrane. A fibrinoid layer separates the deciduo basalis from the placental villi, resulting in abnormally invasive implantation of the placenta. We have this situation when we have placenta previa. The incidence of placenta accreta has increased tenfold in the past 50 years to a current frequency of 1 to 1,500 deliveries, largely as a result of the increase in the number of cesarean sections, and mortality rate is approximately 7%. The most common indication for the birth-related hysterectomy. Degrees of severity. The first, accreta vera, in which the placenta adheres to the myometrium without invasion into the muscle, increta, in which it invades to the myometrium, and percreta, in which it invades to the full thickness of the uterine wall and possibly other pelvic structures, most frequently to the bladder, because it's situated before the uterus. Risk factors. The first, it include placenta previa with or without previous uterine surgery, previous myomectomy, previous cesarean section, Asherman syndrome, submucous layer myoma, and maternal age more than 36 years old and older. The risk of maternal and fetal complications increase, notably after the 35th weeks, exceeding 90% after the 36 weeks, as associated with a degree of invasion. Higher risk is the association between placenta previa and placenta accreta is strong, with a relative risk of 2,000 compared to women with a normally seated placenta, and highest risk, placenta previa itself raises the risk for accreta due to implantation of a highly vascular, poorly contractile lower uterine segment. An existing scar in the same area as well visually compounds the risk. Prenatal risk probability. Because of the fact that many of these cases become evident only at the first attempt to separate the placenta at delivery, it is essential to attempt to identify antenatally both placenta accreta and its risk factors, the most common of which is concurrent placenta previa. Placenta previa. Placenta previa is less frequently diagnosed as gestational age advances due to the so-called placental migration phenomenon. A diagnosis of placenta previa is unlikely to change after 32 weeks gestation. Incidence of placenta previa fall with advanced gestational age, 76% at 17 weeks gestation and 3% at term. Diagnosis of placenta accreta, ultrasound investigation, Doppler and MRI. Management, the first is medical, make progesterone, spasmolytics, surgical, uterine packing, and conservative. Bell-inch sutures, a woman meets the criteria for the Bell-inch compression sutures if bimanual compression decreased the amount of uterine bleeding by abdominal and perineal inspection. We make this Bell-inch suture after cesarean section, during cesarean section, after delivery of the baby, after separation of the placenta. We make this suture to compress the uterus and the main vessels of the uterus. Uterine artery ligation and hypogastric artery ligation, it's the main management tool. At this picture they saw that we find the uterine arteries and hypogastric artery and right common iliac artery, and they make ligature, and it's for prevention the bleeding. Hysterectomy. Resort to hysterectomy sooner rather than later, especially in cases of placenta accreta, when future fertility is out of concern. Selective arterial embolization, it's help too, but very often we make conservative treatment of placenta accreta as very alternative, but substantiated treatment is to leave the placenta undelivered and treat the patient with methotrexate. Some part of placenta live in the uterus. Thank you so much for listening of this lecture. I want to make some note about postpartum hemorrhage, one of the major causes of maternal death, and in the UK, 2003 and 2005 years, hemorrhage is the third highest direct cause of maternal death. There is evidence of substandard care in the majority of fatal cases. In 58 cases they have this problem. Therefore, maternal deaths were preventable. In Scotland, the rate of life-threatening hemorrhage more than 2.5 liters or women who received more than 5 units or women who received treatment of coagulopathy after an acute event. And it's very important to know, I want to talk about it, about the causes of postpartum hemorrhage, about rules of T. The first is a tone, abnormalities of uterine contraction. The second is a tissue, retained products of conception. The third is a trauma. And if we have trauma of genital tract, uterus, some cervix, vagina. And the fourth is thrombin problems, abnormalities of coagulation. If we know about the T rules, after delivery we can help the pregnant woman and prevent the bleeding. Risk factor prediction. The first, present antenatally and associated with a substantial increase in the incidence of postpartum hemorrhage. Suspected or proven placental abruption, placenta previa, multiple pregnancy, gestational hypertension, and advise this woman to deliver in consultant-led maternity unit with a blood bank on site. Present antenatally and associated with significant smaller increase in the incidence of previous postpartum hemorrhage, it's anemia and obesity. Become apparent during labor and delivery, emergency or elective cesarean section, retained placenta, mediolateral episiotomy, prolonged labor more than 12 hours, big baby more than 4 kg, pyrexia in labor, age more than 40 years old. Maintain extra vigilance. Women who had a previous cesarean section, check the placenta site by ultrasound investigation. Women with placenta accreta percreta, it's check and make diagnosis during ultrasound investigation too. It's very important to know about it. Most cases of postpartum hemorrhage have no indicated risk factors. Sometimes they have initially, the first time, normal delivery, normal weight of the baby, and they have bleeding. The first, what we need to know about prevention and prophylaxis on the third stage of delivery. Active and expectant management. I want to talk about oxytocin injection after delivery of the baby. We have active management is associated with a lower maternal blood loss and reduced risk of postpartum hemorrhage, but it's associated with an increased incidence of nausea, vomiting, and raised blood pressure. Practice active management of the third stage of labor. It is prophylactic oxytocin versus no uterotonic. Oxytocin reduces the risk of postpartum hemorrhage by about 60% cases and the need for therapeutic oxytocins by about 50%. Offer routine prophylactic oxytocins to all women. And it's very important to do it. Prophylactic ergometrine oxytocin and oxytocin, symptometrine oxytocin and oxytocin with prostaglandins. It's very important to use these drugs too because it's prevent postpartum hemorrhage too. And thus balance the advantage of a reduction in the risk of postpartum hemorrhage of between 500 and 1000 milliliter blood loss against the adverse effect associated with the use of just prostaglandin. For women without risk factors for postpartum hemorrhage, oxytocin is the agent of choice. Symptometrine may be used in the absence of hemorrhage and it's reduced the risk of minor postpartum hemorrhage but increase vomiting. For women delivering by cesarean section, use oxytocin 5 unit or maybe 10 units intravenous. Prostaglandins, injectable uterotonics are preferable. We prefer to prostaglandins for routine prophylaxis. Misoprostol is not as effective when compared with oxytocin in preventing. It also carries increased adverse effects, which are dose related. However, it may be used in a home birth setting. It's very important to use both of these drugs, oxytocin and prostaglandin, for preventing postpartum hemorrhage. Maybe if we have a big fetus, risk of hemorrhage, the weight of the fetus more than 4 kilograms, we think maybe we have multipurpose pregnancy, maybe we have polyhydramnion and widened uterus. We need to use oxytocin injection after delivery of the baby, and we need to use prostaglandin if we have risk of bleeding and if we have bleeding. And I want to make a little bit note about carbetazine. It is a longer acting oxytocin derivative. It is licensed in UK, but in Azerbaijan nowadays we have this drug, and especially for the indication of prevention of postpartum hemorrhage in the context of cesarean section. A single dose, 100 milligrams of carbetazine, is as effective as oxytocin by infusion. Don't use it routinely because of the paucity of data and its high price. That's all. Thank you so much. And some words about anesthetic management. To assess the woman quickly, to initiate or continue resuscitation to restore intravascular volume and provide adequate anesthesia, the presence of cardiovascular instability is a relative contraindication to regional anesthesia. Blockage of the sympathetic system can potentially lead to worsening hypertension due to hemorrhage. If cardiovascular stability has been achieved and there is no evidence of coagulation failure, regional anesthesia can be used. Continuous epidural block is preferred over spinal, as it allows better blood pressure control and the prolonged surgery. When there is continued bleeding and the cardiovascular stability is compromised, general analgesia is more appropriate. Rapid sequence induction is the gold standard to reduce the risk of aspiration. The therapeutic goals of management of massive blood loss are to maintain its hemoglobin more than 80 grams per milliliter, platelet count more than 75, prothrombin more than 1.5, and mean control activated prothrombin times and fibrinogen. Fluid replacement, total volume of 3.5 liters of clear fluids up to 2 liters of warm Hartmann solution as rapidly as possible, followed by up to a further 1.5 liters of warm colloid, or if blood still not available, is the maximum to be infused while awaiting compatible blood. The nature of fluid infused is of the less importance than rapid administration and warming of the infusion. Blood transfusion, if fully cross-matched blood is unavailable by the time then 3.5 liters of clear fluid have been infused. Group 0 RH negative blood is the safest way to avoid a mismatched transfusion. In an extreme situation and when the blood group is unknown, give 0 Rh negative red cells. They may be incompatible for patients with irregular antibodies. For most women, the ABO and rhesus groups will have been determined on a current admission sample. If not, testing on a new sample takes 10 minutes, then ABO and D group compatible and cross-matched blood can be issued. If irregular antibodies are found or are known to have been present on a previous occasion, then blood must be cross-matched. Antibodies may delay cross-match greatly. Antifibrinolytic drugs. You must know that fibrinolytic inhibitors such as tranexamic acid may have place in the management of hemorrhage. Blood components, and when the blood loss reach more than 5.5 liters, it's 60% of blood volume, and large volumes of replacement fluid have been given, there will be clotting factors defects, and order these blood products as soon as the need is anticipated, as there is a short delay in supply because of the need for thawing.